Let me give you a quick introduction on how to stage your patients using the AAP classification. You are only going to stage and grade patients who have periodontitis. Now, if your patient has bone loss, and maybe it's from ortho or from bruxism, and they've never had active periodontitis, you do not give them a stage and a grade. These are for patients who have had periodontitis or are exhibiting periodontitis currently. They will need a stage and grade. Your perio maintenance patients who are coming back in, you should assign them a stage and a grade because they've had periodontitis in the past. What staging helps us do is it gives us the extent and severity of our patient's condition. It tells us how much bone loss there is. What I recommend doing first is what you've already been doing. First, you expose your radiographs. We're going to look at the bone. If we see some cupping, some fuzziness, maybe less than 10% of bone loss, those patients will be under stage 1. If we see 15 to 33% bone loss, those patients will be in stage 2. And anything that is extended from the middle third and beyond, so about 34% and up to 100% bone loss, those patients will be in stage 3 or stage 4. Now, what's the difference between stage 3 and stage 4? Let's look down here below. The difference is if I have a patient who has lost 5 or more teeth from periodontitis, not from caries, I'm going to put them in the stage 4 category. Now think of that patient. They have advanced bone loss. They've already lost teeth from active periodontitis. Those patients will be stage 4. If they have advanced bone loss and they have not lost yet any teeth, they will be in stage 3. Now, this line above that says interproximal clinical attachment loss, what is that? We don't measure this very often. The textbooks do teach us how to do that, but mainly we're using probe depths. What they're asking us to do in this scenario for interproximal clinical attachment loss is they want us to measure the pocket. This example here is a 9mm pocket. Then they want us to determine how much tissue is above the CEJ and then subtract, and that will give us our accurate amount of how much tissue, our supporting tissues, the patient has actually lost. Now, I don't do this a lot in my private practice or clinical practice because I know that a 9mm pocket is advanced, right? We already know that. We can already put into our mind that if we have those deep pockets, 7s or above, even 6s and above, that's getting to the advanced stage of loss. But I do want you to consider how much actual loss is there. Look at that tissue. Is it really inflamed and swollen? Do we have, maybe some swelling that might not cause that clinical attachment loss to be quite as much? I know that we're already considering this, but I don't actually document it. I'm continuing to document my probe depths currently. So what you're going to do then is choose the greatest stage and document that. For example, if we have generally we have stage 1. Everything is, we have some slight bone loss everywhere, but maybe on tooth number 15, we have 30% bone loss. What we're going to do is just say that that patient then has stage 2, their AAP classification is stage 2, so localized stage 2. Instead of like saying generalized stage 1 with localized stage 2, we just give 1, which makes it really easy for us to be able to stage our patients if we're just giving them 1 and educating them on that. Stay tuned for more information about staging and grading.